Okay, great. And that's the first time in a long time that I've seen a session getting early. So congratulations to the organizers. And maybe if Dr. Rahul and Dr. Manish Jain agree, we can also say that we will put a pick line for all patients with lung cancer and we can stop it right now. So Dr. Rahul and Dr. Manish sir agree?
Yeah, I can agree for that.
हाँ तो सर मतलब बोल देते हैं कि हर पेशेंट में पिक लाइन लगाएंगे, पहले पिक लाइन लगाएंगे, फिर बायोप्सी करेंगे, फिर कीमो देंगे, so that we can go even home earlier. Okay.
That's true.
So, but still we have to, discuss something about PEC line, choosing a right CVAD. And my first reactions, as I normally, whenever I see a topic, I normally have my first reactions. Most of them are crap. This is even more crap. This was like CVAD in a lung cancer masterclass. I mean, this is an out of syllabus question. I really thought, what are we doing pick lines and ports, but I thought in a breast cancer symposium or a colorectal, we have long infusional chemotherapies and maybe vesicants chemotherapy is absolutely okay. Then I thought maybe I'm in a wrong meeting. Then maybe, I got an invite for something else. But, there we are. And then I actually looked at the list of all the distinguished speakers. So I thought, Kumar is a nice guy. He wanted to invite me to the meeting. So he just have given me some topic to discuss. All the big topics have been taken off by the other biggies. So, Dr. Minish, I will start with your point. Venous access, this is something which we normally don't discuss. But it can actually dramatically affect a patient's ability to receive appropriate treatment. Do you think we need to discuss this topic more frequently, or what is your take on that? Is the topic timely? Is it relevant? Is it useful?
Yeah, I think we are not discussing something because we are increasing the length of our treatment times now. We are increasing it to 1 year, 2 year, and then we are not discussing something which is more important, that how to infuse it. If we do not have good access and if we do not develop good team to handle intravenous care, how are we going to use treatments which are going to be for such prolonged period? And most of the treatments are now becoming prolonged. So if with immunotherapies, with monoclonals, with so many things happening, everything is going to require an access. And we should discuss this more frequently. And I think Kumar has taken up the topic, and it really, when I joined oncology in 94, 95, we used to discuss Pickline, Groshong that time. But after that, I have never seen it happen in last 20 years.
Okay. So 94, 95 was the time I joined MBBS, sir. Okay, that's great. Dr. Rahul, what's your take on this?
I think it's a very pertinent topic, and we tick all these boxes which you made, and we know that without a venous access, we cannot proceed. So I think that is the stepping stone to our therapy. And more importantly, majority of our patients come routinely for, again, testing their blood, and every time they need to be pricked. So I think venous access is very, very important. Starting a venous access, maintaining it, taking care of it, and without that, we cannot give chemotherapy. So I think it's a very, very pertinent topic.
I think also very important, honestly, we always do counsel the patients for a breast cancer, for a PICC line, or a port, maybe colon. Lung cancer, it never actually it actually always escaped my attention. Till the time I actually did one of these classes topics, and I actually found out, one of my patients was getting immunotherapy at the thumb. And somebody was getting the lower limbs. And I was here somebody spending 2 lakh rupees of treatment on nivolumab. And why didn't we even discuss this? Probably it just skipped my mind. It was not useful. So just imagine a nivolumab, let's just think about lung cancer. Somebody gets 6 cycles of GemCarb. You have by and large got 12 pricks at least for the infusion for the chemos. Add to it, you have blood sampling every time before that. That makes it 24. Some test before that guy must have done. That makes it 30. You have 24 sessions of nivolumab. That makes it 54. Some blood samplings in between, some samplings in between. That makes 68 to 70, man. I just got a prick last time. My daughter got a prick when she had a dengue. And I jumped out of my bed and I just got a blood test, and it's painful. I mean, I think it's actually very relevant, and from there onwards, last 2 3 months, my perspective about a central venous line has changed. There are also medical legal issues. One patient had extravasation to, one of the drugs, and patient comes to me with etoposide, and arm like this. I actually don't want to see that patient now, and the patient also doesn't want to see me. So I think very relevant topic, very timely and very useful. I totally agree with you. Again, very, very important. 70% of patients who have got irritant vesicant chemotherapy got phlebitis. Very easy to say, put some thromboflob, यहाँ thromboflob लगा लो, hep gel लगा लो, बर्फ की सिकाई कर लो, and then you look the other way around. But just think if it's one of our relatives, it's a very distressing thing to be poked in the cannula again and again. And 22% of people actually get extravasation. So I want to bring both of you, Dr. Rahul, first. Extravasation in your setup, has it increased, decreased, changed more? Or how do you think it is?
No, it's very common and it is increasing because as the number of patients increase and the number of chemotherapies increase, especially in breast where we give dose-dense chemotherapy and we try to give weekly paclitaxels, the incidence increases. For the staff, it is very easy to probably say that this vein can be ignored and we go to the other. In breast, even more when we know this patient has undergone surgery and one arm cannot be used itself. So vesication is very, very common, and we see it once a patient has come for the next cycle and we see the arm is already having vesication, and we are probably helpless and looking for what you mentioned, maybe an extremity, a thumb, or for an access. So very, very common and very worrisome actually, vesication.
Okay. Dr. Minish, sir, your comments?
The number is not that big, but because as we said that, the number of patients are increasing, what we are seeing is more frequent now. Earlier, the percentage was more. Now the percentage of vesication is low. But if a patient gets any extravasation, that leads to an ulcer, leads to delay in treatment, very expensive. Sometimes the patients are even following up with me for years to say that, this fibrosis is not going, these movements are restricted. There are difficult times. We cannot explain them that this extravasation was because of the chemotherapy. And every time, as you rightly said, for that patient, we have to really put our face on the other side and try and say something and go away. So I agree that, this kind of thing should never happen. Even for 1% patient, it should not happen. The number 22% is not that common with us. It is maybe 1-2% extravasation. But those extravasations, even in a port extravasation or a fractured port, have created big troubles for us. Sometimes, that has also created trouble. In fact, today morning I was seeing a patient whose port is a problem and the chemo got delayed. There is like bacteremia, central line related infections. These are things which we should avoid. Peripheral extravasation, this we should avoid. So we require training. We require more care. We require to put in more efforts to understand this topic.
I think more importantly, we need a change in mindset, sir. I mean, that is very, very important. I'll just give you an example. There was a patient of mine, 6 cycles of pemetrexate, 12 cycles of pemetrexate maintenance. She's got exon 20 insertion. And then she got CKD. So, we diagnosed CKD, we withheld her chemotherapy, we did all those things for her. Then the disease progressed. I also have applied for amivantamab, compassionate access. So, all doing very, very good. In the meantime, I wanted to give her paclitaxel. I gave her paclitaxel, new sister, a new daycare effort, and she had an extravasation. Trust me, the patient forgot everything. And they came and fought with me so much, sir, I said, yeah, come on, I have done so much for you. I'm getting you 10 lakh rupees, Doug, free of cost or something. They just didn't bother, sir. Some new attendant came and started shouting at me that, and again, medico-legally, sir, and I also spoke to people, medico-legally, whether it is a sister who does an extravasation or whatever, it is a treating doctor actually who is liable.
Responsible.
So that's a very scary effect actually. And the very simple answer was to me, doctor, we have been with your treatment for last 1 year. If we can afford this much of treatment, then why didn't you counsel us for a PICC line or port? I was, I was actually stumped. Very few times that I am actually lost for an answer, and I didn't have an answer to give to them. So, I think it's a very important topic which we need to discuss even further. Not only in lung masterclass, we should discuss in breast masterclass, GI masterclass, head and neck masterclass, whatever masterclass, we should discuss that actually. So that's it over here. Now, these are the venous access devices that we have actually. We have a peripheral IV cannula. We have an ultrasound guided peripheral IV cannula. That's the same thing. We have midline catheters. We recently in our ICUs, they are actually putting midline catheters, central venous, a subclavian or a jugular vein. Then we have a PIC or a tunnel catheter or a port. So my question for you, both of you, sir, I'll start with Dr. Rahul, is how do you decide which chemotherapy, which venous access device to be put for which patient, sir?
So one is the duration of chemotherapy and the type of chemotherapy that we are going to give. If we have to give infusional chemotherapy like 5FU, we definitely require a PICC line or a port. We are very comfortable with the PICC line, so we go for that. Also, if the patient has a long-term chemotherapy, which is 2 weekly initially and then weekly, we definitely go for the PICC lines. And in case there are vesicants or irritants, we definitely go for the PICC line or the port. But if the patient has a monthly chemotherapy, probably a doxorubicin, which has to be given once a month or something like that, then we encourage them for a peripheral IV cannula. But yes, one most important thing is how the patient is going to manage the PICC line and how compliant he is in taking care of the PICC line.
I will come to that. At the roadblocks, I'm going to come to.
So that is what we think. Yeah.
Okay, so you basically think the duration of chemotherapy, the type of chemotherapy, the length of treatment that we're expecting is a major determining factors as far as your practice is concerned. Fantastic. Dr. Manish, sir?
Yeah, I think, see, what we are looking at is how long the treatment is going to be, what is the pH, osmolality, what is the vesicant, irritant, what we are going to use, how long we are going to do, how much is your intensity of treatment, whether the patient is motivated, whether the patient understands. See, when PICC line, we have to make sure that the patient appropriateness is also very important. Whether they're going to come up for regular flush, whether they're going to be accessible. Otherwise, port is a better choice if the flush is not going to be possible. A lot of our patients are from periphery. So in that situation, sometimes even PICC line care is not available with them at 100 kilometers or 200 kilometers from the city. So in those situations, we cannot put up this kind of PICC line. So then we motivate them for port. If the access is very good, if it is a male patient with a good access and we are going to require only 4, 6, 8 doses, then we don't even force them for a central line or anything. But if it is a female, chubby, fat lady, or, lines are a problem on day one, then we don't wait too long for them to land up into trouble and then go for a port or PICC line. We try to motivate them as early as possible. So that, and that is discussed as a part of treatment cost itself. Most of at our place, most of the time it is port rather than PICC. But I think what we are trying to now change in last few months is going towards PICC. We were doing more port because that were more easy at our place.
So absolutely right, sir. I think this is how you decide. I think there are two questions that I ask myself before when a patient comes to me. The first question when I ask about myself is, does the patient need, okay, from the TMS they're asking. Okay, one thing is that the first thing that we are decide is a central venous access or not. A PICC line or a port, yes or not. If it is yes, then I decide about the PICC or port. And definitely, as both of you have said, the type of infusates, the duration of treatment, the intensity, the vascular integrity. Again, a personal anecdote. One of my own relatives was there and I was giving a weekly Paclitaxel carbo. And again, you don't want to expose your own relatives to all these PICC lines and ports and everything. So I didn't give for 2-3 cycles. At the end of it, I had to put a PICC line port because the veins ran out of it. And again, as the problem with treating your own relatives, they came and told me, this is such a good thing. Why didn't you do it earlier? So, doctors and especially relatives are difficult to treat at that time. Okay. This is what is shown over there. If you, this is just the green is the appropriate, yellow is the neutral, inappropriate, disagreement. So if you have a irritant or a vesicant infusion, PICC line goes green for everything. If you have a chemotherapy for duration for less than 15-30 days, then port really doesn't make a difference over there. Frequent phlebotomy, again, yes for the PICC line. Port is obviously a red for the phlebotomy actually. Again, to say most chemotherapy agents are either vesicants or irritants. You know, you look at this list. I think if I had put this list at the beginning, and maybe BARD should do this, they should give a list of irritant and vesicant drugs to all the doctors. I think, and the list of medical legal compensation which people have been provided, every doctor will put either a PICC line or a port actually. So this is here, one of the major issues which have been there is basically the duration. So Dr. Rahul, I wanted to ask you, how much, what is the maximum amount of PICC line? You know, one thing which I came across from your point was that if you have a long duration, you would prefer a port, but if it's a short duration, chemotherapy, 4 months, 6 months, you will want a PICC. What's the maximum PICC line that you have actually used it for?
So, majority of our PICC lines work for 6 months. We extended some PICC lines up till 8 to 9 months, but we have never gone beyond a year. So I think that is what we have.
Dr. Rahul, you have not gone beyond because you have not gone, the PICC line has not gone, the patient has not gone.
Yeah. So now all the three factors, either the chemotherapy has got over, or the majority of the time the PICC line has got infected or thrombosed.
Okay. So fair enough. All three of them, you have not gone beyond 6 months.
Yes.
Dr. Manish, sir?
See, tunnel catheter, the longest I have used Hickman for 3 years. But PICC line we have used mostly for up to 6, 7 months, 5 months. That is what is the average. Most of the time after that it was either neither used, or most of the time we thought that, it is now time to change or remove it. So there were certain issues like tracing issues, peripheral infection, suspected rigors. We did not really pursue it because it was easier to pull it out. So those kind of things happened. Yeah. But most of the time we could pull it on for a few months easily. So
again, sir, very thankful to the pandemic of webinars, because in this one of these pandemic of webinars, I did a moderation like today for the CVAD. And my gut feeling again, and I'm the most guilty person in the venous access this thing today. I used to take it out in 6 months time and say, "Ki 6 mahine chalti hai," and port will go for 2-3 years. That was my first statement. But then I looked at the literature over here, and 4 guidelines actually have said that, PICC lines can go for 12 to 34 months actually. Having said that, after that for ovarian cancer patients, especially because, we give them paclitaxel and then when we take the PICC line out, that's what I used to do. And then when the relapse comes, I used to call them again. There are 2 of my patients who have now gone beyond 12 to 15 months and there's absolutely no issues. Again, this was Journal of Venous Access Devices and they said PICC lines could be used for 100 to 300 days. This was again a study which basically says 250 patients, median dwell time was 184, but the range is from 15 to 1,384 days. Again, can be used again. So again, the zinc patients. So let me understand the barriers. So let me ask you, Dr. Manish first. Sir, in last 100 patients of chemotherapy that you have given across all cancers, how many of them you have counseled for PICC line, and how many or a port, and how many of them have actually got the things? And so let's say you're saying 100 patients, you do counseling in X, and finally the turnover rate is in how much, sir?
See, as I said, most of the time when we counsel, the patient agrees to it. It is never that we counsel and they don't agree.
Sir, आप मुझे सिखा दो counsel कैसे करते हैं. My results are absolutely dismal, sir. बताइए, sir.
No, because counseling we do it to the right patient and right kind of thing. So generally they don't disagree to it. The issue is not that. The issue is that our motivation for PICC line has been low, as I said, at our center. Port has been higher, and most of our patients, 80-90% of our patients are on port rather than PICC. So, but we are changing recently. We have started changing to PICC. We have got a very good interventional radiologist who is picking up PICC lines very well. So we are now changing for that.
So, sir, can I ask you, because I can see someone coming on the dais and asking me to stop another 2 minutes. How much time do we have, yeah?
13 seconds only.
13 seconds only. Okay, so can I take 1 more minute, please?
Yes,
okay, so Dr. Manish, What will help you in changing over from port to PIC, and what are your roadblocks?
No, my roadblock was only one, that we did not have that many staff to handle the dressings for PIC line. For port, we don't have to do that, and because our center is very busy, our nursing staff is very limited. PIC line was an issue because every time the patient comes for a dressing, we require staff.
So regular dressing and lack of trained people. That is what the one thing.
No,
for you.
Trained people are there, but they are
now.
Limited number.
Okay, Dr. Rahul, what will help you changing from port to PIC?
No. So we have always been the PIC. So we've never been the port, and
so what will make you shift from PIC to more PIC? Pickers.
Yeah. So being from the government institute, we have plenty of PICs. We have plenty of manpower for changing and putting PICs.
On a scale of 0 to 10, sir, how much will you rate your satisfaction? And forget it's a bad symposium.
It's a 9.5 because it's a 9.5 and only half a mark, so that I know we're not all 100%. So and being from a teaching establishment, we train our residents also on those things.
And sir, so Dr. Rahul, last one before somebody comes over there and switches me off. Who does the PIC line insertions for you?
Yes. So initially we start putting PIC lines on our own, but over a time period, our nursing staff has been trained. So they are further disseminating this knowledge. So we feel that train the trainer and train further. So that is what we follow. And now we've got a good team who keeps passing this on as we go forward too.
So I can tell you, yes, sir.
When I started my career in oncology, I was the one who was putting PIC lines.
Wow.
So we used to have this. We used to have these Vina cats, which were long catheters, which we used to put. I used to do it myself for all my patients. I was the resident at Bombay Hospital, and Hinduja used to do all these things. But then eventually we lost this because the other things.
That was a fantastic thing, sir. So we had a person to come up. 10 more seconds. We had a person who used to come and do, and now we have nurses who are doing this. Our residents are not really doing it, but nurses doing it. Trust me, the best decision that we have taken, and the things have become very, very, very easy actually for us. And so I think a lot of times, I think BARD has got association with I think this Practo, and they are doing dressings at home also. So I think that's very, very, very easy for us to manage. And I definitely think that we should actually put the PIC lines or a central venous access for everyone, because that's my last closing statement. Our team is only as strong as its weakest member. Even if your weakest member has an IV cannula or a new sister who has goofed up that, trust me, the patient will have a lot of complaints against us, and we will have a lot of face-saving issues with that. With this, thank you, Dr. Manish, and thank you, Dr. Rahul, for a fantastic deliberation. Thank you.